Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is 26 June 2025. This video is on a JACC article titled Effect of Frailty on In-Hospital Mortality and Complications of PCI, an NCDR registry report. There's free access to this report. Last author is Dr. Deepak Bhatt. There's an accompanying editorial titled Frailty and PCI Outcomes, Turning Registry Insights into Health System Action. More than 50% of PCI procedures occur in adults above the age of 65. Frailty reflects physiological vulnerability influencing outcomes. There's limited US data on frailty prevalence and impact during PCI. So the study authors used data from the NCDR cath PCI registry, included patients from October 2018 to December 2021. 1,316,390 patients above the age of 65 undergoing PCI were assessed. Frailty was assessed using the Canadian Study of Health and Aging Clinical Frailty Scale, CFS, and it's categorized as no frailty when the CFS score is 1 to 2, pre-frailty when the score is 3 to 4, frailty when 5 to 6, and severe frailty 7 to 9. The primary outcome was in-hospital mortality. The secondary outcome was bleeding, transfusion, stroke, dialysis, and vascular complications. They adjusted for logistic regression. They used adjusted logistic regression for outcomes associations. What did they find? The in-hospital mortality by frailty status. When there's no frailty, it was 0.5%, less than single digits. Pre-frailty, 1.1%. Frailty, 3.3%. And in severe frailty, it was double digit, 20.3%. Bleeding increased from 1% in those with no frailty to 8.9% in severe frailty. Transfusion rose from 1% to 14.7% across the frailty spectrum. Mortality in cardiogenic shock was 20.8% in no frailty patients to 51.1% in severely frail. The key takeaways: frailty is common and significantly predicts PCI complications. Even pre-frailty increases procedural risk. Shared decision making should integrate frailty status. Radial access is preferred to reduce bleeding in frail patients. The accompanying editorial commented the strengths. This is a large data set assessing frailty in PCI. They used validated clinical frailty scores to stratify frailty with robust statistical adjustments. This highlights real-world applicability via the NCDR cath PCI registry insights. The limitations: frailty assessment was subjective and non-expert based on chart abstraction. The CFS ideally reflects pre-illness status, but may reflect acute presentation here. The registry lacks post-discharge outcomes or patient-centered metrics, example, quality of life. These findings underscore the need for randomized trials targeting frailty mitigation strategies. The editorial also emphasized that frailty as a vital sign. Routine pre-frailty screening can optimize patient-centered care and guide shared decision making. They said that integration of frailty assessment into health systems alongside team-based geriatric and palliative support is essential to tailor interventions and improve outcomes. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.